Yeah, you start presenting.
Okay. So,
Yeah.
this is about an 1-year-old female. Mrs. Rudrashri informed the father, presented with a complaint of sudden onset of bluish discoloration of body 2 days ago. History of presenting illness. The baby was apparently normal before 2 days. Uh, 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 2 days back, the baby developed bluish discoloration of the body uh, uh, during a crying episode, which approximately lasts for 2 to 3 minutes, and it released spontaneously in squatting position in the mother's lap. There is no previous similar episodes. There's no previous similar episodes. There's no history of any fever. There's no history of any recurrent respiratory infection. There is no history of any feeding difficulties. There is no history of any previous hospitalization. And there's no history of headache, vomiting, or convulsions, or any muscle weakness. Obstetric history. The baby is born of non-consanguineous marriage. It's a spontaneous conception. Maternal age at conception is of around 6 years. Antenatal period was uneventful. Uh, Antenatal scan taken at specific times were normal. There's no history of fever with rash in the antenatal period. There is no history of any maternal smoking or alcoholism. Birth history. The baby is born by a full term normal vaginal delivery of a birth weight of 2.3 kgs. The baby cried immediately after birth. No history of cyanosis at birth. No history of NSG admission. Family history. This baby is the only child for the parents, and there's no history of any congenital disorder that run in their families. Developmental history. The baby can stand and walk with support at now. Other milestones like head control, rollover, social smile are attained at the age without any developmental delay. Diet history. Baby was exclusively breastfed till 6 months of age. There's no issue of any bluish discoloration during feeds until now. Immunization history. The baby is immunized up to the age. So summary of the history. This is about an 1-year-old female baby found to have a cyanotic spell 2 days back and during an episode of crying with no any other symptoms of any cardiac illness. General examination, anthropometry. Height is 75 centimeter, weight 8.5 kgs. Head circumference was 41 centimeter. There's no pallor, icterus, or cyanosis, clubbing, lymphadenopathy, or pale edema. There is no any external markers of congenital disease like mongoloid phases of polydactyly or syndactyly, column of iris, low set hairlines or low set ears, or neck webbing. Vital signs: pulse rate was of around 120 per minute. Normal in character in volume. There is no radial or radiofemoral delay. Blood pressure is of around 110 over 77. Respiratory rate is around 25 per minute. Oxygen saturation is around 86 in room air. Airway examination, both nostrils were patent and it's a Malamati one. There's no receding mandible. Systemic examination, cardiovascular system. Inspection, chest is symmetrical. There is no any visible pulsations. There's no scars over the chest. Palpation, inspected findings were confirmed by palpation. Apical impulse is felt at the left fifth intercostal space at the level of mid-clavicular line. there is no parasternal heave, there is no any palpable thrill. Auscultation, S1, S2 is felt, so here. Systolic murmur is here at the left second intercostal space, close to the sternum. Regarding the respiratory system, trachea is in the midline. Bilateral chest movements are symmetrical and normal. Bilateral lung fields and auscultation, normal vesicular breathstones were here. The perabdomen, it is soft. There is no organomegaly and bowel sounds were here. Regarding central nervous system, baby is alert, active, and playful. There is no focal neurological deficit. Summary. This is about 1 year old female child with a history of cyanotic spill 2 days back during crying, which is relieved by squatting, with the finding in the examination of systolic murmur here in the left third intercostal space, left second intercostal space, close to the sternum, with Roma saturation of 86%, with no signs and symptoms of cardiac failure.
Yeah, good. Dr. Kaushik, you want to continue?
Yes, sir. So the first thing is, we'll start with the history. I don't want to interrupt you when you're presenting. So we'll start with the history first. Okay, you said that the child had cyanosis, and then you had other history that you asked for, like recurrent respiratory tract infection. So could you tell us why you had asked specifically?
Regarding the recurrent respiratory tract infection, since the child had an episode of cyanosis, with the babies, sorry, the patients with increase in the pulmonary arterial hypertension, they may have presenting with the recurrent respiratory infection. The history of recurrent respiratory infection is can able to differentiate between the cardiac cyanosis and the other causes of cyanosis.
Okay. Recurrent respiratory tract infections usually. What is your diagnosis? I didn't get that. There was someone who asked that also. What was your diagnosis? You summarize the findings and everything.
Findings. The baby had a cyanotic spill 2 days back with in the examination, the baby had an room acid saturation.
The summarizing again, I want a diagnosis. Your provisional diagnosis. That's how you.
Provisional and diagnosis is that baby is having an cyanotic congenital heart disease, which needs further evaluations.
Good. Okay, so you're talking about a cyanotic congenital heart disease with no signs of infective endocarditis, no signs of congestive failure. Okay,
yes, sir.
That's how you need to summarize. And if you have your rhythm, you also need to mention the rhythm when you're putting together the diagnosis. Okay.
Yes, sir.
Yeah. So the specific reason why you need to ask for respiratory tract infection in these cases is supposing you have a like borderline saturation, say 90 to 92%, then you're talking about pulmonary artery infection. Usually in cyanotic congenital heart diseases, you are not going to have pulmonary hypertension picture because there is no blood going into the lungs.
Yes, sir.
Okay, so when you're talking about pulmonary hypertension, that means there is a lot of pulmonary flow. Okay, so
yes, sir.
That scenario does not happen. Can you tell me some scenarios where that happens when you have a excessive pulmonary blood flow in cyanotic heart disease?
Transmission of great arteries, sir. total anonymous pulmonary venous connections, sir.
Good, that's one.
Or in case of truncus arterios.
Okay. Yeah, so that's good. So whenever you have excessive blood flow, pulmonary hypertension scenario, these are the first few things which we are talking about. Okay. Or in cases of Tetralogy of Fallot. So we have more or less narrowed down our diagnosis to Tetralogy of Fallot. That's what is going to be kept most often for exams. So in Tetralogy of Fallot, always whenever you have other arteries which supply the lung along with your pulmonary blood flow, there can be arteries which arise from the aorta and supply to the lung. In all those cases, you will have excessive blood flow into the lung, and that can present you with recurrent respiratory infections rather than cyanosis. Okay, so they are called MAPCAs, major aortopulmonary collateral artery. Hello?
Yes, sir, I'm audible, sir. Yes, sir, I'm audible.
Yeah, okay. Okay, so I'll give you some scenarios and we'll just move on from there. Okay.
Okay, sir.
So if this child is going to come to you and you are in a peripheral hospital and it's coming to you, how old did you say the child was?
It's a 1-year-old child, sir.
Okay, so 1-year-old child, he comes with a history of trauma. Okay.
Okay, sir.
And you have a open fracture and you want to, what would you do? What would be your plan of management? That is one scenario. I'm going to give you another scenario. You have the same child who's come in, probably this guy was 2 years old, little later age, probably around 3 to 4 years old. He's come, come with altered sensorium, okay, and they're suspecting some CNS pathology.
Okay.
How would your management vary in these two scenarios? So one is he's come to you, you know that he's got a known case of Tetralogy of Fallot.
Yes, sir.
It has not been corrected, and he's coming to you for a emergency surgery.
Okay, sir.
The second is he's gone in for some complications. So what are the most common complications which is cyanotic?
The complications of Tetralogy of Fallot, there can be the child going for congestive cardiac failure, sir, or the baby can go for any thromboembolic manifestations like cerebral infarct or renal infarct, or the baby can develop a cerebral abscess, sir.
Okay, so incidence of congestive failure is very less in Tetralogy of Fallot.
Yes, sir.
Try and avoid saying that in exam. Okay, so you're talking about a brain abscess. Okay, so why do these people have brain abscess?
The reason for brain abscess is that since this child prone for thromboembolic manifestation, there can be an infarct to the brain. With the addition to this, due to the reduced pulmonary circulation, there is a reduced phagocytosis ability in the child. So there is more chance of developing the abscess in the brain, sir.
Okay, so the first thing is thromboembolic events because of polycythemia. So they tend to have a infarct, cerebral infarct, and it tends to get easily infected because of what you said. Okay, so there's going to be a brain abscess. So if you have a brain abscess, so do you want to add something, sir?
Yeah. But I thought we'll go by history wise. I thought you told 1-year-old child developed cyanosis 2 days back. So
Yes,
till then the child was acyanotic, mean normal, and you told it is immunized till age, isn't it?
Yes, sir.
Yeah, so that means that the child would have visited the pediatrician for immunization for till 1 year.
Yes, sir.
And so there is a high chance that these child would have been auscultated or found this thing. This is the first time it has been diagnosed, or
It's first time it has been diagnosed.
Diagnosed. So this sounds a little awkward, isn't it? So because a child, even during birth, usually nowadays, no birth is done without a pediatrician. Usually they auscultate, and sometimes at birth there will be some murmur, okay. But
Yes,
during immunization, usually they would have picked up. And yes, of course, cyanosis can occur a little later also. And usually baby will find it difficult to feed, cry, and so on. And cyanosis would have appeared. And maybe they would have not noticed, or this would have been the first incident. But the most awkward point is it has been not diagnosed till 1 year. That is the this thing. That's okay.
This was a
Then,
kid which came and we just operated on him like last week, sir.
yeah.
Absolutely asymptomatic. Yeah, as you rightly said, sir, it's a little like you don't get such cases very often.
Yeah,
but
that's what. Very
all
often.
the time depends upon the educational status of the patient also. I mean,
Yeah,
of the parents,
correct.
the parents of
Yeah.
all these times.
Yeah, that's correct. Can you? I'll just run a few slides before going. Sir was going in for management of anesthesia. Shall we go a little this thing basis of few things before we go on? I think. Can you see these slides?
Yes, sir, I can, sir.
Yeah. What is cyanosis?
This cyanosis is the bluish discoloration of the body, which occurs due to the increase in the amount of reduced hemoglobin in the body. Usually, cutoff is more than 5 gram per dl, sir.
Yeah. So
this can be classified.
It is not a bluish discoloration of the body. It is a bluish discoloration mostly of skin and the mucous membrane, more of mucous membrane. Since this is a child, usually they notice the lips and tongue. That is what the mother usually sees the baby while crying, and she is the one who takes care of the child from birth. So usually the mother usually finds the cyanosis. So it's a bluish discoloration of skin and mucous membrane. And one more point, Dinesh, usually it is happens in all the postgraduates while in the Viva. You try to answer to the question asked. Because what happens is when you deviate and try to tell whatever you have learned or this thing, the discussion point usually gets diverted, and that's a most worrisome period. No, this is usually comes as a short case, and when you try to tell something extra, the examiner will deviate, and they will go into a point where you don't know something. Okay, that's a general. I'm not trying to discourage, but that is the point. All the exam going PGs for the practical particularly to know. And one more point about the postgraduate going for theory also, same thing. Most of the postgraduates, I have heard that they don't have time to write the theory, all the 10 questions. The problem is they do. There is only the key points they would have noted in each question. Of course, there is some ambiguous questions which they let you to write a lot. Try to answer to the point, or try to answer both in theory as well as in practical to save time. Okay, so that in theory you will have time to complete all the questions, and in practical also the same thing. Okay. So,
thank you, sir.
Yeah, that is about cyanosis. And what are the classification? That's what you were trying to tell. Yeah, tell me.
This can be classified into central cyanosis and the peripheral cyanosis, sir.
Yeah. So central and peripheral, and one more is differential cyanosis. Okay. So, what are the causes of peripheral cyanosis?
So peripheral cyanosis is caused due to the defect in the perfusion defects.
Yeah. So, what you're telling is the cause of peripheral cyanosis. I mean, the pathology, the causes of what are the etiology? I'm telling about like low cardiac output or exposure to cold or any hyperviscosity or any vascular arterial obstruction in peripheral vascular disease and so on. Okay. So, like what are the central causes of cyanosis?
Central cyanosis, it occurs due to defective oxygenation of blood, sir. In case of congenital heart disease, in case of defective oxygenation in lungs, congenital diaphragmatic hernia, or
so in this, you can divide into two things: whether there is any problem with the oxygen saturation. Other one is any problem in the hemoglobin. Okay, so broadly you divide into two. When there is any problem in oxygen desaturation, either it may be due to the oxygen as such in the atmosphere. When there is oxygen supply is low, for example, in the event of high altitude, or any defective pulmonary pathology, any problem where you have an hypoventilation or any ventilation perfusion mismatch. Okay, then you go where the oxygen enters into the body or to the lung, then it enters into the hemoglobin, where hemoglobin is less and it has a decreased affinity for the oxygen. Then comes the anatomical shunt, where comes our cyanotic heart disease or any pulmonary AV fistula. So if you understand this ways, then you can you will never forget to tell or express in the examination part. I mean, in the viva part. Okay. You understand this?
Yes, sir. Yes, sir.
Yeah. So, what is differential cyanosis? So, differential cyanosis is a cyanosis evident in the lower extremities, where upper extremities is normal and cyanosis is there only in the lower extremities. This occurs when there is a congenital, PDA with the reversal of shunt. Reversal occurs due to increase in pulmonary artery hypertension, and there is a reversal. Okay, so the upper body there will be normal oxygenation is normal, and lower body has cyanosis. And there is a condition called reverse differential cyanosis, where the upper body is cyanotic and lower part of the body is normal. In this case, the same thing with a patient has a transposition of great arteries. Okay, that is PDA with reversal with the TGA. Okay.
Yes, sir.
Yeah. Can you name some cyanotic congenital heart disease? One is our case, Tetralogy of Fallot. Then?
Transposition of great arteries, sir.
Yeah, good.
Total anomalous pulmonary venous connection. Truncus arteriosus.
Yeah.
It can be atresia, sir.
Yeah. So just to name few. Okay. When do clubbing appears? Because cyanosis, for example, this baby has cyanosis appears at 1 year of age. Okay. So usually this congenital heart disease patient develop clubbing, isn't it? So when does clubbing appear usually? Cyanosis usually most of the patient appears on birth. Okay,
yes,
immediately after birth, depending upon what actually? The severity of the outflow tract, right? Right ventricular outflow tract obstruction, and the reversal of shunt. Okay, so when do clubbing appear in the cyanotic patients? Usually it takes around 6 months for clubbing to appear.
Yes, sir.
Okay. So coming to tetralogy of Fallot, what are the components of tetralogy of Fallot?
Right ventricular outflow tract obstruction with right ventricular hypertrophy.
Yeah, good.
With ventricular septal defect, with overriding of aorta over the ventricular septal defect.
Yeah, and over the interventricular septum. Okay.
Yes, sir.
So this right ventricular outflow obstruction can be subvalvular, valvular, or supravalvular, or the combination of everything.
Yes,
okay.
Sir. Yes,
so this is the main pathology in the tetralogy of Fallot, this right ventricular outflow obstruction.
Yes, sir.
Okay.
Yes, sir.
Yeah. What are some of variants, if you know? Just tell me.
Variants can be Tetralogy of Fallot, sir. When the Tetralogy of Fallot is combined with an atrial septal defect, it's called Pentalogy of Fallot, sir.
Okay. No, I'm talking about variants of TOF. Okay. There are several variants. Sometimes there will be hyperplastic pulmonary arteries and MAPCOS and
absent
pulmonary valve. Okay, and so on. So these are a few. Okay. So how frequent TOF? What is the incidence of appearance of tetralogy?
Incidence, it's around 3.3 per 10,000 live births, sir.
Yeah, good. Yeah, good. So, moreover, tetralogy is the most common cause of cyanotic congenital heart disease. Yeah. Okay. So, can you name some of the syndromes associated with TOF?
Syndromes, it can be associated with DJAR syndrome, sir, or Down syndrome, or Wattle association, or Charge syndrome, or it can be associated with Patau syndrome, or Edwards syndrome, sir.
Yeah. So just because sometimes some the examiners might ask, this is something they may or may not ask. But most of the times they will ask what is triology of Fallot, what is pentology of Fallot, and what is monology. Monology, this is the first time I'm hearing. Of course, what is this?
Monology, I think it's a right ventricular outflow obstruction, sir.
Yeah.
I'm not sure. Triology, it is a right ventricular outflow obstruction. Along with right ventricular hypertrophy and ventricular septal defects, sir.
Yeah, that is what we have in tetralogy.
But triology, there will be no overriding of aorta, sir.
Okay.
In pentalogy, the tetralogy of Fallot along with the atrial septal defect.
Atrial septal defect, yeah, correct. So, what is the pathology of TOF patients?
The main pathology is the right ventricular outflow obstruction, sir. And that leads to the defective pulmonary circulation. So the right ventricular undergoes hypertrophy. In addition to this, there will be an ventricular septal defect. So there will be mixing of blood in the so the blood in the mixing of blood in the ventricles. So because of the overriding of aorta, the mixed blood will be circulated to the aorta, sir.
Yeah. Okay. Yeah. Why polycythemia occurs in TOF patients?
It is.
What is polycythemia? Polycythemia is increase in the
RBC amount.
Blood cells. Yeah, red blood cells. Okay. Why you have seen TOF patient having hemoglobin of 18, 19, 20, and so on. Why it occurs actually? Why polycythemia? Yeah.
Because hypoxia induced erythroblastosis in the bone marrow, sir.
Yeah. So there is hypoxemia due to the right to left shunt. Okay, but the body needs some oxygen. To compensate that, the body generates more hemoglobin so that more amount, some amount of oxygen is carried and to be delivered into the tissues. So it is a compensatory mechanism because of the cyanosis. Okay. So same thing occurs in smoker patients, where because of this nicotine content and hypoxemia, polycythemia occurs in smoker patients. Okay.
Yes, sir.
So what are the complications which occurs due to polycythemia?
Complications due to polycythemia, there will be increase in viscosity of the blood, sir. So there is a high chance of thromboembolic manifestations, sir.
Okay, good. Okay. Why failure is rare or absent in TOF patient? Sir was actually telling while he was talking about failure. Is failure common in TOF patient or absent or rare in TOF patient? So it is rare or absent because there is a non-restrictive ventricular septal defect.
Yes.
Yeah.
Yes,
So in the definition also on TOF, you have to tell don't mention as simply VST. Particularly in cyanotic heart disease, it's a non-restrictive ventricular septal defect. So it decompresses both the ventricles easily and it avoids the volume overload.
Yes,
okay.
Sir.
Yeah, that is the reason. Okay. Why does TOF child learn to squat in difficult situations?
The squatting is actually it compresses the femoral arteries. So thereby it increases the systemic vascular resistance. So thereby it decreases the right to left shunt.
Yeah, good.
So there will be reduces the cyanosis and the child will become symptomatically better.
The oxygenation. Yeah, oxygenation improves. Okay.
Yes,
sometimes the babies run or during the play, they know that they develop dyspnea and they squat. Okay. That is the history also you take. What is the squatting? That is the reason. Yeah, squatting episodes. Okay, that is one of the important history in cyanotic patients.
Yes, sir.
Yeah, and in the X-ray, we have boot-shaped.
Yes, sir.
Yeah, what is the reason for that?
The boot-shaped heart it occurs due to the right ventricular hypertrophy, which actually pushes the left ventricle, which leads to the development of the flattening of the inferior border, along with the upturning of the apex of the heart, which leads to the appearance of the boot shapes.
Yeah, good. There are this baby was pink till 1 year.
Yes, sir. Yes, sir.
Yeah. So what is that? Why is that?
It occurs when the right ventricular outflow obstruction is only mild to moderate, sir. So there is a minimal amount of pulmonary flow. So thereby the cyanosis didn't occur, sir. This is called as pink tetralogy, sir.
Yeah, good. What is hyperspinotic spell or TET spell?
It is the occurrence of sudden onset of cyanosis in a baby, which is actually preceded by an increase in the respiratory rates.
Yeah. Okay. So there is a sudden and significant decline in oxygen saturation. Okay, already even in cyanotic patients, for example, while we are inducing TOF patient and you see a saturation of 86, suddenly it goes to 60 and so on. So that is the this thing. Okay, sudden decline in oxygen. Okay, due to there is a increase in the right
to left
outflow obstruction. Okay, so there are several causes. For example, this baby, as you told, had on a cry episode followed by cyanosis, isn't it?
Yes, sir. Yes, sir.
Yeah. So there are so many causes of that, and like crying or dehydration or anemia or
defecation,
for
pain.
example, yeah, defecation, something like that. Even anesthesia is one of the cause.
Yes, sir.
Okay. Yes. And what else? I think rest will continue after sir this thing, because after that everything goes into anesthesia and so on. And sir has already started doing that. Okay, we'll stop this share and we'll continue. Yes, sir. Over to you.
Sir,
or anything you want to add or anything? Yeah.
Yes, sir. So if you take all the 4 components of tetralogy, which is the one single component which is most important and which leads to all the rest.
It's a right ventricular obstruction, sir.
No. So what happens is there is an anterior and cephalid displacement of the septum. Okay. So that malalignment of the septum is what causes everything else. Okay. So your overriding of aorta, the right ventricular hypertrophy, and the VSD, all of them arise because of this malalignment of the septum.
Yes, sir.
If you're asked, if there is somebody who is taking an exam of the cardiac anesthetist.
Sir, I'm sorry, sir, your voice is breaking, sir.
Can you hear me now?
Yes, I can hear you now, sir.
Yeah. So the most important thing is the malalignment of the septum. That is what causes everything else. Okay.
Yes, sir. Yes, sir.
Okay, and the second thing is we were discussing about hypercyanotic cells. So I was thinking of asking you when you were doing the case, but we'll go into that now. So what causes this hypercyanotic cells?
It occurs due to dynamic obstruction of the right ventricular outflow tract, sir. So thereby causing right to left shunt, thereby resulting in cyanosis and hypoxemia, sir.
Okay, so there are 2 things happening here. One is because of that right ventricular outflow tract obstruction, like sir said, you are having right to left shunting. The second component that plays an important role is because of this RVOT obstruction, there is no blood going to the pulmonary artery. Okay, so the blood flow into the pulmonary artery is already less. Whatever is going also because of the spasm, it is not going to go into the lungs. So there are 2 components. Okay, one is right to left shunt is going to increase. Second is the pulmonary flow is going to also decrease. Okay, so why does this happen in TOF patients? Like you were discussing, because of crying, because of yeah. So all those stimulants, what will they give rise?
Stimulants that can cause it's a sudden increase in heart rate and a sudden increase in the contractility, sir. So thereby causing the RV spasm, sir. So thereby resulting in the hyperspasmodic spell, sir.
Okay. Can you tell me some other conditions which can lead to this hypercyanotic spell? Let's say it is not a TOF. You have just a cyanotic patient. So what all are the conditions which can increase this incidence of cyanotic spells other than TOF?
TOF patient.
So any condition which has the BSC and the PS, okay, can lead to this. Because every time you reduce the systemic vascular resistance, there is going to be an increase in the right to left shunt. Okay, so any condition where you have a BSC with a PS, you can always end up with a cyanotic spell when you're inducing the patient. Okay. So now since you have, yeah. So what are the other like ways in which? Okay, I'll ask you straight away. What are the theories which can explain this cyanotic spell?
Theories.
Yeah.
They are Wood's theory, sir. Here they state that the scientist will cause. Okay, sir. Wood's theory, Cantor's theory, catecholamin release theory, Morgan's theory, and Young's theory, sir.
Okay. So the most important thing, what explains it in most of these cases, is catecholamine release theory. Now, why you have so many different theories is because there are some scenarios where you have pulmonary atresia. That means there is no blood flowing through the pulmonary valve. Okay. So in all those cases where it cannot be explained by this right ventricular outflow tract obstruction, you have other theories to explain it. Okay. So that is the reason if you see your treatment strategies also will have everything put together. You'll have to increase SCR, drop the PVR, give IV fluid, treat acidosis, okay, and deepen the anesthetic pain. So all of these have to be done simultaneously when you're treating a hypercyanotic cell. That is why you have so many different theories. Okay.
Yes, sir.
Right. Okay. So, sir, can we give them case scenarios or?
Yes, sir. Yes, sir. Yes, sir. We'll go. Yeah.
Okay.
Okay.
Yeah. So. We'll start with start with a child coming to you. Okay, he's going to have a corrective surgery for tetralogy of Fallot. So how would you secure an IV line in this patient? So what are the things you will take care of or beware of when you're securing an IV line? So what I want to emphasize here is securing an IV line itself, that is enough to precipitate a cell. Okay, so that is enough to precipitate cell. So what could you do? What are the options you have?
The options we can have is we can have an English induction, sir. Followed by we can have an IV cannula, sir. Or we can have an intramuscular injection of ketamine. Then following which we can have an IV cannula, sir. The other options were intranasal midazolam or intranasal dexmedetomidine, sir.
Okay. So what is the difference when you are going to go for, supposing you're going for an inhalation induction? What will you see in this patient? Will it be normal or?
The issue with the TOF and the English induction is that because of the reduction in the pulmonary circulation, the time taken for the English induction will be more compared to the other babies, sir.
Yeah, very good. So right to left lesions, always inhalation induction takes longer compared to left to right lesions. Okay, so that is one thing which you need to so okay. You have induced the patient, you have secured an IV line. What are the problems? What other problems can you expect with this patient in securing an IV line?
Since the patient prone for polycythemia, the baby may have a previous multiple episode of phlebotomy, sir. So there can be a difficult venous cannulation, sir. If the child has already undergone a palliative shunt surgeries, we have to a secure line in the opposite side or the femoral, sir.
Okay, that's good, but you're talking about an IV line here. So when you're talking about an IV line, you can secure it on the line of the shunt also. Okay, it does not make a difference when it comes to the IV line. Only for your arterial line, you need to be careful that you're not securing the line on the side of the shunt.
Okay. Yes, okay.
So what will happen if you secure it on the line side of the shunt? What are the types of shunts that you know?
The types of shunt include classical ballot testing sensor, modified ballot testing shunt, water shunt or pot shunt, sir.
Okay. What is the difference between a classical and a modified BT shunt?
A classical BT shunt is actually an end-to-end anastomosis of the right subclavian artery with the right pulmonary artery, sir. whereas in the modified, there will be an allogenic graft which is placed between the right subclavian artery and the right pulmonary artery, sir.
So in both these cases, your subclavian artery is going to be sacrificed. Okay, so especially
yes,
for your classical blood thoracic shunt, you're going to ligate and cut across the subclavian artery, and you're going to anastomose it. Okay, so
yes,
therefore your perfusion into that side limb is going to be
reduced.
Reduced, and it will be taken over by collateral. Okay, so you will not have so your you will try and avoid securing a line on that particular side.
Yes, sir.
Okay, anything else? Okay, so your IV cannulation is over. What is the induction agent? So would you use anything other than ketamine? Why do you?
Sir, sorry, sir, your voice is again breaking, so I can't hear you, sir.
What is the induction agent you use?
And the induction agent of choice will be an ketamine of IV dose of 2 mg per kg, sir. In case of IM ketamine, we can use of 5 mg per kg, sir.
Okay. Okay. Why do you prefer ketamine over other cases?
The ketamine which will increases the systemic vascular resistance, so thereby it will prevent the shunt developing from right to left, sir. When compared to others, there will be a drop in SVR, so that there is more chance of shunt from right to left, so that will resulting in a cyanotic spell, sir.
Okay, when you're talking about ketamine, the reduction in SVR is least with ketamine, and therefore it does not cause a reduction in SVR, and therefore it will prevent any increases in the right to left shunt.
Yes, sir.
That is why you're preferring ketamine. Is there any scenario where you would want to avoid ketamine?
This scenario is that if the same TOF child coming for any neurosurgery, like in case of cerebral abscess drainage, where the ketamine will also increase the ICP, so we have to avoid ketamine, sir.
Okay, good. So whenever a patient comes for brain abscess, usually it will be done with a needle aspiration followed by antibiotic. So if you're going to decompress the brain, that means that the intracranial pressure is already elevated. You would want to either avoid ketamine or give very low doses of ketamine, because all these patients need to have a raised intracranial pressure. Okay.
Yes,
so okay, so you have induced the patient. Now you have connected the monitors. What are the monitors? And where do you want to move? Okay, there are a few things which we missed out. The pre-anesthetic assessment and the investigations, we discussed part of it. There were a few things which I wanted to add. We'll add that in the end. Okay.
Okay.
So we'll go ahead with this. Yeah.
And the monitors include, sir?
Yeah, monitors.
And the monitors include ECG, sir. NAVP at the time of induction that can be changed into invasive monitoring after induction, sir. SpO2, ETCO2, then central venous pressure monitoring, sir. Then urine output monitoring, sir.
So what is the difference you will see in each of these monitors and looking at a particular thing? In these patients, when you're looking at the ETCO2, what
it is ETCO2, since there is there will be reduced pulmonary pulmonary blood flow, there will be a low ETCO2 level, sir. compared to other patients, sir.
Good. Okay. So the way to put it is your EtCO2 is not reflective of the PaCO2 level.
PaCO2.
So you should always note on the baseline PaCO2, EtCO2 difference to keep a track during the course of the surgery. The second thing is your baseline saturation. If it is below 70, we all know that the pulse oximeter is less accurate when it goes to below 70. So we need to go by frequent ABGs rather than the pulse oximeter reading. Okay.
Yes, sir.
Sir, you want to add something?
No, nothing, sir. We'll go ahead.
Okay. Right. So that is about the monitoring which I wanted to emphasize. Okay. So you have induced and you have connected your monitor, you intubated the patient. Next, what would you do? When he is coming for a corrective surgery. What do you mean by corrective surgery?
The corrective surgery, it will be an open heart surgery where the right ventricular outflow will be normalized along with a patch which will be kept in the ventricular septum defects, sir.
Okay. So put it together in one word called
intracardiac repair, sir.
Yeah. You put a VSC patch, you remove all the obstructing RVOT muscle bundles. Okay.
Yes, sir.
That is what is done.
Yes, sir.
Right. So what are the other palliative surgery? When do you do a palliative surgery as compared to a corrective surgery? Do you do corrective surgery for all these patients or?
Palliative surgeries can be done when the child presents with the frequent history of frequent episodes of cyanotic spells, sir, or when the cases are when the cardiac surgery is not possible, as like in case of coronary artery crossing the RV outlet, sir.
Usually palliative surgery is preferred when your pulmonary artery is not adequately developed.
Yes.
Okay. So when your pulmonary artery is very small, you tend to go for a palliative surgery to augment the size of the pulmonary artery, following which it will be a staged repair. The second stage, you will do a intracardiac repair like we discussed. You put in a VSC patch.
Yes,
remove the RVOT obstruction. Okay.
Yes, sir.
Right. So that coronary crossing and all that, trying not to get into complications by.
Okay, sir.
Yeah. So you need to. That's the most common time when we need PT shunt as compared to a corrective surgery. That is when the PA anatomy is not well developed enough.
That's right. Yes.
Right. Okay. So is there anything else you want to do after induction? You secured the line.
The lines.
What is the next one? What about your antibiotic prophylaxis?
We need to give an infective endocarditis prophylaxis, sir. The doses of about supposedly 20 mg per kg, sir.
All 50 mg per kg. Okay.
Okay, sir.
Infective endocarditis prophylaxis is usually given for all of these cyanotic congenital heart diseases. They are unrepaired. Okay, that is what I want to emphasize here. All unrepaired congenital, cyanotic congenital heart diseases coming for any surgery. So if he's going to come for a bronchoscopy or an endoscopy, irrespective of how trivial the surgery is, because the lesion demands it, you need to give the infective endocarditis prophylaxis. That's why they have different areas, different specifications for giving IE prophylaxis. One is for the condition. One is based on the procedure which you're going to do. Okay.
Yes, sir.
So these patients, if they come for any procedure, even the symptoms, you need to give prophylaxis. Okay.
Yes, sir.
Right. So would you like to add something?
Yeah. In the monitoring, I think you missed to tell about temperature probe. That is one that is very crucial in all pediatric patients. And I don't know about esophageal stethoscope. Sir, what is your now? I was using during my post-graduation. Now esophageal stethoscope has gone off. But on exam point of view, I think a few examiners might ask as a postgraduate to mention about the esophageal stethoscope. But for me, last time I used this 22 years back during my post-graduation. After that, I don't have, but sometimes they will ask about precordial stethoscope as a postgraduate, because what is one more main complication of right to left shunt when you put a central venous line or a peripheral line, what you should be very careful about when there is a right to left shunt, when you put a central venous line and flush or give some drugs or this thing, what you should be very careful.
There is more chance of paradoxical air embolism, sir.
Yeah, good. Okay, so that is one. You should be very careful when there is a right to left shunt. Okay, you should aspirate each and every time the central line to flush off all the small air bubbles, because it is very easy that it goes for a paradoxical air embolism. Okay, and I don't know about esophageal stethoscope or precordial, but nothing wrong in telling a precordial stethoscope as a postgraduate in examination. Okay, that is one.
Sir.
And sir was telling about the infective endocarditis prophylaxis. And yes, you have to give for all unrepaired cyanotic congenital heart disease, or when there is a repaired and there is a defect in the repair.
Sir.
Yeah. Or if any patient has any previous history of infective endocarditis, or non-repaired or completed cyanotic repair within 6 months of yeah, you have to give infective endocarditis prophylaxis.
Yes.
Okay. And what is the main goal of anesthesia for TOF patient?
The main goal of anesthesia mainly involves to prevent any episode of cyanotic spells that can be done by maintaining a lower normal heart rate with normal sinus rhythm, with mild depression in the cardiac contractility, increase in the SVR, and reduction in the pulmonary vascular resistance, sir.
Good. So that is the four main criteria. You have to, that is the goal of anesthesia while you anesthetize TOF patient. Okay. And if the patient is on any beta blocker or something preoperatively to prevent cyanosis, it has to be continued in the preoperative medicine.
Yes, sir.
Okay, and one more thing is last week Dr. Rajini was discussing about EMLA cream and this thing, how to candlelight IV line. So that is one this thing about EMLA cream.
Okay.
EMLA. Okay.
Yes.
Yes. That is what, sir. Then we can go about corrective surgery. And yes, sir. Anything more you want to add?
That most of the things regarding corrective surgery is done, sir. It's done on pump, and then so we've discussed about palliation, types of palliation.
Yeah. So during induction or during maintenance of anesthesia, how will you diagnose a patient if it goes for hypercyanotic spell or TIT spell? What are the different? Yeah. How do you say the patient has gone for a TIT spell or a hyperspinotic spell? Like I'll tell you, when there is a sudden drop of saturation, or
Yes, sir.
a sudden drop in EtCO2.
Yes, sir.
Okay, so these things can diagnose that. Okay, how will you manage intraoperative cyanosis, TET spells?
We have to give 100% oxygen, sir.
Okay.
Along with that, we have to increase the SVR by giving phenylephrine 2 mg per kg, sir. Along with that, IV fluids and reduction in the heart rate by means of beta blockers like esmolol or 0.5 mg per mg per kg, or propranolol 0.9 mg per kg can be given, sir. When the child develop acidosis, we have to correct the acidosis.
Yeah. Then I can, as sir was telling about the deepening of anesthesia.
Yes, sir.
Okay. And
hyperventilation to eliminate carbon dioxide.
Yeah. So, what is the fluid you'll be using for this? Yes, ma'am was telling last week. Ma'am was telling about fluids in pediatric. She was discussed a lot about fluid management, and this patient, or particularly this TOF patient, has to prevent dehydration and so on. So the fluid part has to be maintained. Hydration has to be maintained particularly.
Yes, sir.
Yeah. Anything else, sir?
Sir, I think I've covered most of the things which I wanted to emphasize. Ma'am, Rajni ma'am, or Anandi ma'am, if they have anything.
Yeah.
Regarding that.
Starvation has to be. Can you hear me?
Yes, ma'am.
Yes, ma'am. I can hear you.
Yes, ma'am.
We have to mention about starvation has to be minimized, or you have to be hydrating the child. Make sure that IV is started preoperatively, and overhydration also to be prevented. So they have to have a burette set, or they have to have a diginfuser, so that you know about how much exactly you are giving. And in the TET spell, I think oxygen we forgot to mention. Okay. Starvation has to be minimized. That has to be taken, and then about hydration. And all the pediatric cases, I think we can't take it for granted that everyone is aware of the nil per oral protocol. So it is worth repeating in each class that NPO guidelines for pediatrics.
Yes, ma'am. So, as ma'am was asking, so what is the NPO guideline for a pediatric patient?
The NPO has to be for 6 hours for solids, and 4 hours for the breast milk, and 2 hours for the clear fluids, sir.
Yeah. Okay. What is the investigation? Of course, sir was started and stopped actually. What are the preoperative investigation you do for these patients?
The investigations include complete blood count. As the child have polycythemia, have to look for HB hematocrits, sir. Since they are more prone for infections, we can look for total count, sir. They are also more prone for the thrombocytopenia. So we have to look for platelet count, sir. And we have to look for a baseline urea creatinine, sir. We have to look for ECG, and we have to do an echocardiogram to find the degree of aortic obstruction, sir.
Yeah. Sir, what is your comment about cath in these patients? Right ventricular, I mean,
The CAT is usually reserved for accessory information. Most of the information is got by echocardiography.
Yeah.
Now, in case
When
big,
yeah, when we do a proper echocardiography, usually most of things will be covered in echocardiography. And nowadays, most of the cardiologists or surgeons prefer to do a CT angiogram for these patients. So they cover everything. So previously they used to do catheterization, but now I've not seen any surgeon doing it. There, sir, in your center, how they do?
Sir, usually we stick with CT angio, sir.
CT angio.
But of course, a lot of economical issues also involved. Because,
yeah.
That's the reason. I mean, definitely, when you compare the diagnostic value, I would go with the CAP
yes,
rather than
yes,
CT.
yeah.
More often than not, we do it.
So CAP,
okay. When you get more information.
Okay. So one question is, what is the anesthesia for TOF patients in cath procedures? So whether you go for GA or yeah, of course, all the pediatric patients have to undergo GA, and whatever procedures we do for cardiac surgery inside OT has to be done the same way. Okay, then one more question is, what is the plan of anesthesia? As you told, there is a fracture both bones. So for example, a fracture limb, lower limb. Can we give caudal for these patients?
This baby may also have an coagulopathy, sir. So better to avoid neuraxial, sir.
Yeah. Okay.
The most important thing along with your coagulopathy, when you're giving a neuraxial, you're going to be dropping the
SVR.
That is for a period of at least for however long, for a longer duration. Not talking about just an induction agent, just an anesthetic induction. You're talking about a duration of 2 hours, 2.5 hours. Okay, so your SVR is going to be dropped. So there is a very limited role of neuraxial blockade for most of the cyanotic congenital arteries. If they're coming for when you have an option of neuraxial blockade, you should always think of regional and general, not of neuraxial blockade.
Yes, sir.
Yeah. Anyone want to ask any questions, or you want to add anything? I think Dr. Muthukumar is also there, and if sir wants to add anything, you can also add, sir. So anything, if anyone wants to ask any questions. Yeah. Dr. Muthukumar, how are you?
How did you identify me?
About the questions itself, I know it is Dr. Muthukumar. Yeah, tell me. Yes, sir. You want to add anything?
That's why I came. Usually, we have seen the coagulation factors and other things will be normal in these patients, like PTINR, APTT will not be so much deranged. And we used to check these coagulation parameters before giving caudal. And if coagulation parameters are okay, I think we can go ahead give caudal. And neuraxial block will not cause any hypotension in babies. We have given spinal, we have given caudal. They don't cause hypotension as such in babies where there is no sympathetic development much. So for 2-3 cases, we have given caudal for coming for some tender place repair or something like that. And we have to check coagulation parameters before giving any time.
So you mean in cyanotic patients?
Yeah. TOF patients who are repaired or still having unrepaired TOF or anything. And when I asked Dr. Ramesh about it, he also told the same thing, like better to have a coagulation parameters done prior giving to caudal.
Yeah, that is one. But as an exam point of view,
better to avoid giving, better to tell that you have to do a coagulation profile and then decide on it.
No, an exam point of view, it's better not to tell regional. Yeah, you will avoid because of drop in SVR. Yeah, it is practical point of view. You can do most of the things sir was telling, but exam point of view, it is better to tell.
Better to avoid. What he told was correct. What Dinesh told was exactly correct.
Yeah, yes. So we'll avoid regional and particularly in cyanotic patients. Yeah. So anyone want to ask anything, any question?
We have to always add that these patients after surgeries have to be nursed in the high dependency unit, even if it's going to be a minor procedure.
Yes, yes,
Yes, ma'am.
yes, ma'am. So what about post-op analgesia in these patients? For example, it is corrected, okay. If it is comes for some non-cardiac surgery and the pain has to be managed properly, because these aggravated pain can precipitate cyanosis.
Yes, sir.
Yeah.
The post-operative pain management, it must be multimodal, sir.
Yeah.
In the pain management, NSAIDs can be preferentially avoided due to the bleeding manifestations, sir.
Okay.
We can go ahead with the paracetamol, or along with that, opiates of the fentanyl of 0.5 mg per kg, sir. Along with that, if any chances of any peripheral nerve block is appropriate for the surgery involved, we can go ahead with this, sir.
Yeah. I don't have any experience about peripheral blocks in 1 year or so babies. Dr. Kaushik, what is your saying about peripheral nerve block for post-operative pain relief in these patients?
So when it comes to ICR, we do ESP, sir, rectus sinus.
Okay. Yeah. Okay.
But that's as much as how much we do, sir.
Yeah, that's what. If it is some like fracture, baby's leg, what that is the case scenario you told. Well, like, can we go ahead and give nerve blocks?
Definitely, sir. Definitely, sir.
Yeah. So that is one, and I don't know
for even for post-op analgesia.
Yeah, post-op rather than going for central neuraxial block.
Yes, sir.
Yeah. So, anything more? Anyone want to ask, sir? Ma'am is there? Yeah. If it is, so we'll next week we'll be talking about anesthesia for scoliosis surgery and costoclavicular block, and on postgraduate from Ganga Hospital will be presenting about a case for scoliosis surgery, and then 15 or 20 minutes presentation about blocks. That is about next week, Tuesday. And if anyone wants to come forward to present some cases, then you can just text me. We can arrange for that. And thank you, Dr. Kaushik, Dr. Rajini ma'am, and Dr. Muthukumar for sharing your thoughts about this. And Dr. Dinesh, it is a good presentation. And,
thank you, sir.
Hopefully, most of the things about cyanotic heart disease has been covered.
Yes, sir.
There are last week Dr. Rajini discussed about a lot about pediatric anesthesia.
Yes,
and we'll discuss few of pediatric cases also in future. That is our plan. We'll every week we'll have one, so that all 1 year we can cover most of the topics. And this TOF is usually asked both in theory as well as in practicals. That is why I asked, and we had this session, and no more than Dr. Kaushik can discuss about pediatric anesthesia. And thank you, sir, again for spending almost 1.5 hours for this session. Thank you. If anything is there, you can ask, or we can wind up. Yeah, if there is no question, we can wind up. And if you have any questions, yes.
I have one last thing to add. That boot-shaped heart, when we were discussing, it is always a component. There are 3 components even of boot-shaped heart. You need to mention the upturned apex. You also need to mention that the PA, that is the pulmonary artery, is hypoplastic in these patients. So that part of the segment is concave, along with polygynia. So all of these 3 have to be there for it to be called a boot-shaped heart.
Boot-shaped heart. Yeah.
That is the only thing I want to add. That time, just remember it.
Yeah. Yeah. Thank you all. Good night. We'll see next week Tuesday for anesthesia for scoliosis surgery. Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you, sir.